I think the debate on whether you stop at 24 weeks versus continue in the non-certolizumab-based biologics will remain controversial. There are reports that the biggest risk is that the mom flares in the third trimester. And again, going back to what I noted about inflammation, we want the baby in the third trimester to continue to grow. Important, the brain, the gyri start to smooth out and there's more, the neuroplasticity growth. Inflammation has been shown to impact cognitive and emotional behavior in children born to mothers with active inflammation. So the idea being that they've tested genes in the cord blood to show that they're at risk of increased developmental abnormalities. I mean, this is a big thing. And so we're just starting to catch up to that. And what's out there in other diseases and in animal models is the biggest study. But so I say inflammation from the time you're thinking about it, and then follow that into during breastfeeding and the postpartum. We don't want you to flare because the hormones change again. So it's complex. This is not something that you just say, oh, you're pregnant, you can continue meds. You need to have a really important education discussion because the knowledge base of a lot of even physicians and patients, we're not up to speed on it because we're not exposed to it that often. So being able to send patients to physicians who specialize in this, who are very interested in counseling women, which is a big passion of mine, I think is really important because there's so much we don't know. So, part of also the question I often get is, do you ever switch a patient from one therapy to another because, for example, concern of placental transfer? So this is what I have to say, is that I think if you're starting a woman on a biologic, particularly TNF, which is where there's this distinction between certolizumab not crossing, for example, and the other, both adalimumab and infliximab, yes, to cross, I think you have that discussion with the patient and you decide what is the best drug for the patient right now sitting in front of me. You may take it to the fact that next year she wants to conceive. And I see a lot of women where that decision was made and they come to me to just confirm that that's the right treatment choice. So I tell everybody that the most important solution is please choose the one that matches what the patient needs. If it ends up that she's a female patient and she ends up on certolizumab versus infliximab, I'll deal with the timing of it thereafter. Just get her on the right drug. That's my big push. Then in terms of would I ever intentionally switch someone who's well on one over the other because she's about to get pregnant or is? The answer is no. Our big teaching point is if you have a woman who's controlled inflammation, keep them on that therapy. Goes back to the whole theme that inflammation control is what we focus on. Whatever it takes to get that female patient under control from the inflammation, that's what they need to be on during pregnancy.